Good morning, ladies and gentlemen. Can you hear me?
Yes, yes.
Okay, thank you. It's a pleasure to attend, although virtually, to this meeting and present the topic that has been assigned pathophysiological aspects of primary electrical disorders. The goal of this presentation will be to overview for each of the major primary electrical disorders, also called the channelopathies, the underpinning mechanism for arrhythmic events, and also to take a look to the new strategy for preventing these arrhythmias that are based on molecular approach called the gene therapy. So sudden cardiac death, as we know, is a major proportion of cardiovascular death. It is estimated that approximately 25% of sudden cardiac deaths are related to ventricular arrhythmias. So here we see from a study in United States that these events affect mainly males. There are some gender differences in individual diseases. For example, in long QT syndrome, and especially long QT syndrome type 2, there is a female prevalence. Here is the mean age of the population based on autopsy data. So when we see here the culprit, we can identify that acute coronary artery disease in the young population account for a smaller proportion than it does in the older proportion of the older population. And on the other side, we see that between primary electrical disorders and cardiomyopathy, that are the inherited diseases, we have, especially in the young, a very high percentage. So cardiomyopathy, 63%, and primary electrical disorder, 16%. This number change, and of course, in the older population, the major substrate is acute and chronic coronary artery disease, but still we have a substantial contribution for genetic conditions like cardiomyopathy, 31%, and much less primary electrical diseases, that is 1%. So here we see all the cardiomyopathies, and on the lower panel, we see the electrocardiogram, distinguishing electrocardiogram of the channelopathies. As a matter of fact, in the establishing the diagnosis of channelopathies, the traces of the electrocardiogram is really the fingerprint that allow to establish the condition in the patients. It's interesting to see that we are talking about inherited channelopathies, but the concept that the signal of the electrical activity, the basic one that is the electrocardiogram, already contains a very strong proportion of factors that are genetically determined, and especially the characteristics of the key proteins that are mainly ion channels. And therefore, it has been demonstrated in this study that the 40% of the features of the electrocardiograms are inherited, so that in the family, the electrocardiogram of parents and siblings may be very similar, even in the absence of an electrical disease condition. So just the normal electrocardiogram can have traits that are similar in factors like, for example, the repolarization may be very distinguishing, with some family having larger T waves and some other individuals have a very flat and smaller T waves. So when we look at the protein involved in inherited arrhythmias, are the one encoded by the genes that mainly express cardiac ion channels. So here we see ion channels as transmembrane proteins, mainly located in the sarcolemma, that we see the external membrane. However, we should not forget that one very important ion channel, the cardiac rhyoanidin receptor, is part not much of action potential duration controlling proteins like the potassium channel, the sodium channel, and the calcium channel. But on the other side, this ion channel is fundamental for controlling calcium release and calcium levels inside the cells that are really critical also for the controlling the contractility of the heart. So looking at what Kumel, the big scientist that has digged into the mechanism of arrhythmias, we have different components for the development of arrhythmia. At this time, there were not genetic components identified yet, and we now know that it's very important, the genetic substrate. At that time, the focus was on conditions like ischemia, metabolic abnormality, dysonic conditions like hypokalemia, for example. And then the concept was that there need to be a substrate, but then there is a trigger that very often may be the autonomic nervous system that precipitates the specific arrhythmic event that may occur in a specific day. And there was one concept kind of fascinating in the name, that is the need of having a perfect storm, that is accepting of a condition that may occur at one moment in time, but in the presence of a substrate that through a trigger leads to the arrhythmias. And this is still a concept that is valid today. Starting from the inherited arrhythmias, I would like to begin with catecholaminergic polymorphic ventricular tachycardia. And what I'm showing here is the typical bidirectional ventricular tachycardia with two morphologies of the PVCs. And this rhythm, as bidirectional VT, can be stable for several seconds, minutes also, but then abruptly precipitate into ventricular fibrillation. When we look at the bidirectional morphology, immediately we think to the most classical representation of cause for bidirectional VT, that before the identification of a genetic disease, that is, as a matter of fact, the CPVT, the major cause was digitalis toxicity. And that points to the fact that bidirectional VT is a disease in which the important culprit and the trigger is altered calcium regulation. So in clinics, definition of CPVT is that of a disease that is identified as a highly malignant one, meaning with a high mortality if the patients are not treated with beta blocker therapy. An ECG that is difficult to identify in normal sinus rhythm. Therefore, the patients need to be exercised to unmask that they may have exactly this marker of the bidirectional ventricular tachycardia. Maybe the only abnormality, subtle abnormality that we can see in the resting ECG is the presence of a very small, in some patients, as in this one, presence of a U wave. So clearly, to identify this disease, if a patient comes to your attention and has experienced syncopal event during exercise or emotion, and there is not the presence of a long QT, the next suspicion should be CPVT, and you need to exercise the patients to identify whether these arrhythmias develop. And here you can see another documentation. So sometimes it starts as a bidirectional, then becomes a bit more polymorphic, then it goes back to bidirectional. And at the end, if the patient is not stopped or is not taken care of, will go into ventricular fibrillation. Here is another electrocardiogram that I'm showing to you just to highlight the point that is not that in all the 12 leads, you identify the bidirectional VT. There are some leads in a patient that may show you that this is a bidirectional VT, while in other leads, it seems to resemble more an irregular polymorphic ventricular tachycardia. Let's take a look now to the genetics of CPVT. There are typical catecholaminergic VTs that are the one that were the first to be identified, caused by gain of function mutation in the ryanodine receptor. Gain of function means that the protein, in this case the ryanodine receptor, is hyperactive. So the role of the ryanodine receptor is that of timely releasing calcium to initiate the systolic phase. And the opening of the ryanodine receptor is mediated by a very precise crosstalk between the L-type calcium channel and the ryanodine receptor itself. So we know that in the plateau phase of the action potential, there is the opening of the calcium channel that brings a little signal of a small amount of calcium that is sufficient to open the ryanodine receptor, and that actually is the one that releases the calcium amount that is needed for the systolic contractility. Then we have another form of typical CPVT, so another CPVT where we can observe in the majority of the patients the bidirectional VT. Calsequestrin is a regulator of the ryanodine receptor, so it works in conjunction, physical contact with the ryanodine receptor. And it has a very special role. So on one side is a calcium buffering protein, very important to bind the calcium inside the sarcoplasmic reticulum, so that there is a storage of calcium bound to the calsequestrin that is ready for the release when the ryanodine receptor opens. On the other side, the cardiac calsequestrin has another role that, as we will see, is very important nowadays to think about molecular therapy in a precision medicine approach to treat this condition. In fact, calsequestrin is able to stabilize the closing of the ryanodine receptor during diastole. That, of course, is very important because we don't want to increase the calcium in the cytosol at a time in which the sarcomeric proteins needs to be relaxed to enter in the diastolic phase. The majority of patients, as we can see here, are part of the typical CPVT. So you can expect in these patients to find mutations in the ryanodine receptor gain of function and in the calsequestrin mutations that damage, mainly impair the polymerization of the monomer of the calsequestrin, and therefore there is a lack of the protein calsequestrin. Then there are other less typical CPVT that, as we see, represent a small proportion. They are quite rare, so they represent 1 to 2% of the total of patients with the diagnosis of CPVT. And here we have a triadin abnormality. So these are loss of function mutation of the triadin gene that works in partnership with the calsequestrin to regulate the ryanodine receptor. Then we have the calmodulin, again, a very small proportion. Tacrel is an interesting form of CPVT because while all the other genes are genes that have a really fundamental role in the cardiac cells to regulate calcium, Tacrel is, as a matter of fact, you see here the name of the function and the name of this protein, that is trans-2,3-adenyl-CoA reductase-like protein. So it's a protein that actually works in the regulation of lipid metabolism and similar to another protein that effectively modifies the length of the chain in the lipid triglycerides. So the concept anyway is that also this Tacrel may contribute to regulate the calcium and influence the calcium. So everything recapitulates. Loss of function mutations in the ryanodine receptor at the beginning were considered part of non-typical CPVT. Nowadays, it seems that they are part of a different disease, and as a matter of fact, the arrhythmia typical of loss of function mutation in the ryanodine receptor is not bidirectional VT, but is generally a VF that starts quite abruptly in the patients that have loss of function in the ryanodine receptor. So when we look at whether it matters to distinguish the typical from the less typical CPVT, I think that this slide gives the answer. So in the loss of calsequestrin and in the gain of function of RYR2, typical CPVT, we have an occurrence of events that doesn't really change over time, and it goes from a small percentage of patients developing life-threatening arrhythmic events at very young age, And then after puberty, around the young adult phase of life, more events occur and they can persist up to the age of 40. That is where this paper has looked as a follow-up. So we can really see that the non-typical forms are the ones that are more aggressive and more malignant. And also, while we know that the typical one responds very well to the treatment with nadolol, and when nadolol is not sufficient itself, the addition of flecainide can really provide a satisfactory protection in a good percentage of patients. We don't have such a clear signal of what could be a treatment for this non-typical CPVT, whereby the use of the defibrillator in these patients has been advocated because we really lack a drug that can be more effective than or as effective as in the typical CPVT. So this is an image that I want to show you just to go over what I said of the interaction between the L-type calcium channel and the ryanodine receptor. One very important function is that this L-type calcium channel releases the signaling calcium that activates the opening of the ryanodine receptor. When the ryanodine receptor opens, the calcium can detach from the calsequestrin buffer and be released in the cytosol. This calcium, of course, is partially used for generating the contractility at the level of the sarcomeric protein, but partially also needs to be eliminated and extruded from the cardiac cells, not to keep higher than normal level in the cytosol of calcium ions. So this extrusion of the calcium occurs using the sodium-calcium exchanger. The stoichiometry, however, of the sodium-calcium exchanger is such that when this exchanger takes one calcium with two positive charges and put it outside the cell, so in the space external to the cytosol of the cardiac myocytes, it does that in exchange with 3 sodium molecules that enter inside the cytosol. So if 2 positive charges go out and 3 positive charges comes in, we have a net balance of 1 extra positive charge. We know that the potential inside the cell is negative, and therefore this exchanger that serves a very important role of avoiding calcium overload in the cytosol is, however, exposing the cytosol to a change in the potential in a depolarization pattern. So delayed after depolarizations develop for this excess of sodium that comes in and depolarize the cell. And it is in fact that delayed after depolarization occurrence is the key mechanism underpinning arrhythmogenesis in CPVT. In this condition, CPVT, we have more than 150 mutations that have been described. As you see, all this color represent different domains of the protein. The protein is not a single protein, but is a tetramer. You know that several ion channels are made of 4 monomers of the protein. And in the center of where the monomer aggregates, there is the pore, that is the portion that exchanges and regulates the inflow or outflow of the main ion channel. That, of course, for the ryanodine receptor is the calcium, as we have described. So here you see all these names that are the different portion of the protein that serves different activity. One concept that is important is that the ryanodine receptor is a very large macromolecular complex. What is a macromolecular complex? A macromolecular complex means that there are not only the 4 subunits that makes the core channel, but there are many proteins that bind on different of these domains to fine-tune and finally regulate the function of the channel. the more a channel needs to be regulated, the more delicate is the function that is doing. And therefore, the ryanodine receptor has all the feature of being a macromolecular complex, because the amount of calcium cannot really exceed inside the cell what is the perfect balance. So all these other proteins are also regulators of the function of the ryanodine receptor. So how do the mutations alter the function of the ryanodine receptor? Let's start from physiology in a normal heart. The ryanodine receptor, here you see each of these is a monomer, so it means that the gene that encodes the ryanodine receptor produces a monomer. Then the assembly of the channel is when 1, 2, 3, 4 monomers get together. They create a hole in the middle, because the structure is such that when 4 monomers attack to each other, there is a channel in the pore in the middle that forms, that allows the transition and the exit of the calcium from inside the junctional sarcoplasmic reticulum. So in normal condition, the ion channel in diastole is perfectly closed, and it opens during systole. However, when we look at the physiology of CPVT, we observe that we have calcium leak during diastole, and this leak occurs because perturbation that the mutation is making in the assembly of the tetramer. So it is the mutation that causes this calcium leak in diastole that, of course, can contribute to generating delayed after depolarization. And here we see that systolic function is normal as in a normal heart. So the key action is here, the leakage of calcium during diastole. Other abnormality created by different mutations can be, for example, in regions where the folding of the protein, you see that the protein is not a string that is linear, but actually has to make all these loops to put some residues in contact that serve important function of the channel. So, for example, here we have an N-terminal domain that is the very beginning of the protein that has to fold to put these two set of residues. So here there are different amino acids that needs to be in contact. And if there is a mutation, either on this side or on this other side, as you can see, the schematics here says that you can no longer keep these two tight together, and therefore you perturbate the tertiary structure of the protein that again generates this inability of keeping the diastolic phase closed and having no flow of calcium during diastole. The last theory that has been advocated to explain the calcium release during diastolic has been proposed by Wayne Chen. And as you see here, the concept is that in the sarcoplasmic reticulum, you have a certain amount of calcium that is lower than the threshold for spontaneous calcium release. In fact, in a normal heart, even when we have adrenergic activation, the calcium increases, but it never goes beyond the threshold. So there is little or no calcium spillover in a normal RYR2 channel. However, when we look with the presence of the mutation in a channel with a patient with CPVT, what we can see is that during adrenergic activation, the level of calcium in the SR is higher than the threshold for calcium release. Therefore, severe SR calcium spillover occur. So we have seen here at least 3 different mechanisms that concur to the culprit of the genesis of CPVT, that is the diastolic release of calcium. So if we now compare the recessive form, where we have a loss of calsequestrin, and the dominant one that I have just described, that is the ryanodine receptor gain of function mutation, we can see that the lack of calsequestrin is a major player also in the dominant form, because as we have said, if there is a calcium leakage, the only protein that has the function of trying to maintain the closest state of the channel during diastole is the calsequestrin. And I'm insisting on this concept because actually this concept is now the substrate for one of the potential specific therapy, precision medicine approach that will tackle the abnormality of the function in CPVT. So there is a convergence of CPVT1, ryanodine receptor gain of function mutation, CPVT2, loss of function mutation in the calsequestrin. So what we see is that calsequestrin might in principle be able to counteract the diastolic calcium leak induced by the mutation in both forms. So we started investigating this hypothesis based on this concept that at the end, the problem is that the beta-adrenergic stimulation enhances both in the recessive and in the dominant form the release of calcium in diastole. So we thought that maybe if we have a model of RYR2 mediated CPVT, and here we see a recording of cells that first of all demonstrate that not in the wild type, but in the mutant, when you pace a cell rapidly, when you stop, you have delayed after depolarization. So this means that you have the mechanism that may elicit arrhythmias. In fact, if in these cells taken from the heart of a mouse with CPVT, we superinfuse isoproterenol, we see that when we stop pacing the cell, we keep having spontaneous triggered beats that, in a cell are actually triggered action potential. In a heart, they become triggered arrhythmias. And here we see that after a while, after that pacing is no longer there, the DADs get smaller and smaller, and the arrhythmia in this single cell terminates. So we thought that, the concept that just this little amount of current created by a delayed after depolarization can depolarize the heart and create arrhythmias, seems quite difficult to accept, because we think normally that the cells are well coupled to each other, and therefore such a small current might really be unable to trigger arrhythmias. And as a matter of fact, this in silico study by Jim Weiss and collaborators demonstrated, this is a simulation, a computer simulation, that it takes not just one cell that develop a DAD, because a single cell, due to the coupling of the surrounding cells that remain at -90, if there is only one cell that develops DAD, it will never propagate, because the others will actually turn negative the potential in the cells that started having a DAD. So in this simulation, if you have one dimension aggregate of cells like a cable, it needs that 80 cells oscillate in synchrony to propagate the arrhythmic episodes. If we have a two-dimension, so if we have a layer of cells where you have the two sides of a monolayer, it takes 7,800 cells. And when you have the reality, that is the heart, 3 dimensions, you need really 800,000 cells that simultaneously oscillate. So the fact that the cells are coupled to each other is very important, because it tends to limit the amount of arrhythmias triggered by delayed after depolarization. And we will see that is the same concept applies also to the early after depolarization that we will see being the players in long QT syndrome. So there is a tendency of the system to buffer the development of DADs, but when the amount of calcium increase in CPVT is massive and it really involves the majority of the cells or a large number of cells, that is when the delayed after depolarization occurs. A lot of interest has been raised on why the CPVT arrhythmias are bidirectional and what is the electrophysiological mechanism. So again, in another study in silico from Jim Weiss, they simulated the onset of bidirectional VT and observed that in their model that was fed by the characteristics at the level of calcium and ionic currents observed in vitro studies reported in the computer, that the alternance of the morphology is really associated with the location, as we can imagine, the site of origin of the arrhythmias, whereby an extrasystolis with a left bundle branch block morphology alternates with one with right bundle branch block, at variance with polymorphic VT that has a totally irregular site of origin that can be at different points and gives this other morphology and aspect. Whether the bidirectional VT originates from Purkinje fibers has been debated and has been a very hot debate among scientists, especially basic scientists. A very interesting experiments were done by the group of Dr. Halife, where they took a mouse, actually they had our mouse model because we were collaborating on this effort, and they painted with a substance called Lugol blue. That is a substance that kills specifically the Purkinje fibers. So interestingly, by painting on the site, on one side of the heart, the bimorphic, bidirectional VT would convert into a monomorphic VT. So this study has been quite supportive of the concept that the Purkinje fiber may be the origin of the bidirectional morphology in CPVT. So this is just to show you that the other forms, the more rare one, triadin, tekrel, and calmodulin, that are the non-typical CPVT, are non-typical because their arrhythmias are different, and mainly they are polymorphic VTs that start abruptly and rapidly degenerate into VF. And as I have said, there are no medications that have proven effective in this setting and in these conditions. So this is just to show you one of our patients that, first of all, the arrhythmias started at rest. So there is no need in the triadin knockout individuals to have an arrhythmic trigger like emotion or stress. But even at rest, this arrhythmia can initiate. And as you see, they don't have not even a polymorphic VT, is really an abrupt onset of VF, more similar to what occurs in Brugada, as we will see. Calmodulin, again, exercise does not induce arrhythmias, so we don't have a trigger that we clearly can identify and limit in the patient's lifestyle. And tekrel as well, polymorphic ventricular tachycardia, in this case during exercise, in some other patients not so clearly associated with exercise. So in CPVT, we have attempted two gene therapy strategies. Here I'm showing you an RNA-based gene therapy. In biology, it is very well known that there is a property of the cells that can sense that one protein should not be produced at a certain level, and is called RNA interference. Very small molecules of 20 residues of RNA can interfere with the production of a protein. So we decided that maybe for dominant CPVT, CPVT1, we could design an RNA molecules that would specifically silence only the mRNA that produces the mutant protein. Of course, dominant disease, it means that you have two genes for each protein that the body needs to make, one inherited from one parent, one from the other. So in dominant disease, one of these two alleles is mutated, the other is normal. We want to target with our RNA molecule only the mutant allele, leaving normally expressed the wild type allele. So we developed many of these RNA molecules, and then in vitro we identified that the best one was the one called U10, no special reason, just a code that was given in the lab. And so by reducing the amount of the mutant protein, what we see here is that the treated cells that were stained with a fluorescent protein, and therefore we could identify a negative cells, so a dark cell, not green, after the pacing still develops the arrhythmias as we have seen before, but the protein that has, the cell that has turned green because it has been infected and therefore received the curative molecule, as you see, doesn't develop arrhythmias in vitro. The same also occur, of course, in vivo when we give to the animals the same therapy. So this is very fascinating also from a mechanistic point of view, because when we reduce the amount of the mutant protein, we interfere with the ratio between wild type and mutant subunit in the channel. So here in this graphic, the gray area, cylinders are wild type proteins, and the dark are the mutant proteins. Of course, if in a cell you have a lot of yellow conditions, so a lot of channels where all the subunits are abnormal, the proportion of patients that will develop arrhythmias will be higher. On the other side, if you have more of the normal one, you will have less arrhythmic events. Therefore, our approach of reducing the amount of the mutant protein shift the proportion to have more of the light blue and orange proteins that are the ones that function better for a subunit normal, 3 out of 4 normal, and still having some half and half, but definitely reducing the purple and the yellow. So we see here that before the therapy, we have in this setting of before therapy, 25% in the condition of having 3 sick proteins in the tetramer, and 6.5%, 25% of the yellow. When we go after the therapy, we reduce this 25% to 10% and this 6.25% to a meager 1.23%. So we really take out the worst guys, the culprit of the arrhythmias, and we force the system in going in this direction. And this is why this therapy is quite effective, as we can see here, in vivo as well, where here is the animal before the treatment. Here is an animal that received a scrambled RNA, so a piece of RNA that is not doing the job of silencing the mutant protein. And here we have the treatment with our U10 that actually fully prevents the occurrence of arrhythmias in these animals. Then we thought about the limitation of this therapy. The limitation is that it is sequence specific. So you need to design an RNA protein that will specifically silence the level of the mutant protein. But if we know that we have 150, 60, 70 different mutations already described in the clinics, this commercially will be impossible because we would have to have really a patient-specific therapy. So it's a nice exercise. We were happy to demonstrate the proof of concept, but we decided that for clinical approach, we needed to have something that would be broadly effective across the patients. And so we went back to the idea that calsequestrin is very important to help keeping the ryanodine receptor shut during diastole. So we decided to create another gene therapy. This is a virus. In the virus, so we put this portion that is the active part of the therapy, in which we put the sequence, DNA sequence of the calsequestrin, aiming at increasing the amount of calsequestrin, hoping that this would facilitate keeping the channel shut during diastole. That is the main function of the calsequestrin. So we tested 3 doses, a low dose, medium dose, a high dose, and we observed that already the low dose was totally able to blunt the occurrence of the arrhythmias, and then, of course, the medium dose as well, and the high dose as well. If we look here on the animals who still had VT, we see that there was one in the medium dose that still had arrhythmias. So we went back to see which animal was this one, and we noticed there was this one that, as a matter of fact, didn't receive the therapy. So the operator that was injecting made a mistake in this animal. And so unexpectedly, we had this nice confirmation that only the animal that received the therapy were the one that did not develop the arrhythmias, and the single one that failed to receive the therapy developed still the arrhythmias. So, of course, we know that in the calsequestrin knockout, the replacement of calsequestrin is also curative. So we believe that this therapy can be a treatment for patients both with ryanodine receptor mutation and calsequestrin mutation. And at the present time, this therapy has been licensed to a company that is planning to start the clinical trial in humans in 2025. So we will see what happens. And with this, we move now to the other disease, long QT syndrome. In long QT syndrome, there has been a lot of enthusiasm for the identification of different genes. And so very rapidly, in few years, many genes were associated with the occurrence of the phenotype of long QT syndrome, that, as we know, is typically characterized by prolongation, as the name says, of the QT interval and development of arrhythmia that are called torsade de pointes. Over the years, however, many of these genes were really considered not causative of the condition. So there were mistakes, overinterpretations. So nowadays, the situation is that the key genes for long QT syndrome that account for more than 90% of the positively genotyped patients are LQT1, LQT2, and LQT3. LQT1 are mutations that reduce the repolarizing potassium current called IKS. LQT2, hERG, another potassium channel, reduces the mutation here, reduce the IKR current conducted by this gene. And the LQT3 is, on the other side, different because it's a sodium channel disease, because this is the gene encoding the sodium channel subunit. And in this case, it occurs that there is an increase in the sodium current, but not in the peak sodium current, but in the late sodium current that I will describe to you in a minute. If we want to see other forms of long QT that have a gene that has been clearly identified, we have to go to long QT syndrome type 7, where KCNJ2 that encodes for the channel called KIR 2.1 is a potassium channel that controls the IK1 current. The IK1 current is a very important current that occurs at the end of the phase 4 and stabilize the resting membrane potential in the cells, so very critical. Another one where we have a gene, and we know that this really confirmed as a gene for long QT, is Timothy syndrome, where there is an abnormality in the calcium channel that increases the amount of the calcium entering the cells in a mechanism that is similar to the one of long QT syndrome type 3. Both of them fail in inactivating the channel. So if the channel doesn't close at the right time, there will be here an excess of sodium and here an excess of calcium. All the others are not confirmed as really pathogenic genes. The calmodulin seems the other one that may be soon reconsidered as a genetic background for long QT syndrome. Okay, why all this? Well, because knowing which are the substrates that are considered causative allow us to think about, us and the field in general, how can be therapies to treat molecularly and correct the genetic defects, all these forms of the disease. And this is what we will see here. So first of all, LQT1, 2, 3 have different shapes of the repolarization phase. In LQT1, we see this bell-shaped morphology of the T wave. In LQT2, we have these flat T waves. And in LQT3, we have a very long ST. And here what you see is that the ST, and then the T is here, is so stretched and so long that you may have a P that precedes the T in this kind of patients. So really a major prolongation. Of all three, the LQT3 is the one where the patients tend to have values of QT duration that are really above 500 and 550 in several of them. So what can we do now, having this knowledge about long QT syndrome, how we establish the diagnosis? I just would like to point out that for many years, the threshold for diagnosing long QT syndrome has been QT more than 440 milliseconds, corrected QT, in males, and QT corrected more than 460 for females. But already in the guidelines of the ESC in 2015, it was suggested that this early definition was too generous. And by generous, I mean that too many people that really did not have a long QT syndrome phenotype, that remained asymptomatic for their life, despite being above these thresholds suggested at the time, were creating false positive, and therefore patients that were banned for sport, that were living with anxiety related to a life-threatening arrhythmias possibility of occurrence. And so it seemed reasonable in 2015 to change to this threshold, specifying that it should not be something that the doctor, the cardiologist, sees only once, but it needs to be repeated. So the patient needs to come back maybe after 1 month and after another month if he's an asymptomatic patient. So the class 1 for diagnosis is to have a more stringent threshold value and to confirm that this threshold value is not happening in 1 day, but is really a constant feature of the patient. On the other side, if we have a patient that has already had a likely arrhythmic syncope and no other causes for QT prolongation, then we may include such a patient with clinical manifestation, even if the interval of QT that we measure is between 460 and 480. So we make it a bit more permissive when we have evidence that the patient has ventricular arrhythmia and syncopal events, and this is a class 2A. In 2003, we had demonstrated that when we want to think about who is a patient at risk, we had 2 indicators that were significant in multivariate analysis. One, which gene of these 3 the patient has, so is a patient with LQT1, LQT2, or LQT3. And second, the duration of the QT, obviously in the sense that the longer the QT, the higher the probability of having events. So for many years, we had that evidence, but we were not really able, for the numerosity of our patients, to say whether it is more important the gene or more important the duration of the QT. And so it took more years, and we arrived to have a large and sufficient number of patients to address this question. So somewhat surprisingly, for the cardiologist, or at least for me, it seemed more obvious that it would be the duration of the QT, really the phenotype that the QT is abnormal, to be the major player. But no, the major player, as you can see, are the genes. So if we take, for example, a QT in the range 541 and 550, we see that if the patient is LQT1, this very prolonged QT, has a 5-year risk of having an arrhythmic event between 3 and 6%. However, if the same patient is an LQT2, the risk goes up between 6% and 9%. And then if the patient is an LQT3, the risk go even higher and is more than 9%. And I want to remind this because it's a bit counterintuitive, because we have in our hands the electrocardiogram, and we tend to think that is there where we will find the best prognosis. But actually, it is very important that all patients with a suspicion of long QT syndrome get screened, not only for making the diagnosis, but I would say especially for understanding in which risk category the patient is located. So we have created this LQT risk calculator that you can find at this address. So if you want to take a screenshot of the slide, you can try with your patients. It's enough that you put the RR interval that you are measuring, the QT, the QTC, and then the type of gene that has been identified. And you will get, just like in the hypertrophic cardiomyopathy calculator, the 5-year risk predicted for that patient. So here is just to show you that the concept that I was saying, the LQT8 and LQT3 are inward current. And as we already discussed, to prolong the action potential, what happens is that the calcium current is not inactivating, is not closing. It remains always open. And this prolongs the plateau phase where the current is located. Similarly, for the sodium current, we see here, the current does not inactivate and remain persistently open. So what happens in these patients is a very similar thing, that inward currents are the one prolonging the action potential duration, acting at the level in which they are open. And in particular, this is very different from what happened in the potassium channels, and the 3-potassium current on the other side prolong the QT when the repolarizing current, that is the one that drives this ending of the action potential, is not active and creates a situation that prolongs the QT because it takes much more time to repolarize, and would probably go in there. It is true that the LQT8 and LQT3 patients tend to be the one that have the more prolonged QT. So when we see patients with QT, corrected QT always, in the range of 680, 700, immediately we think about LQT8. If it's not LQT8, the next suspicion is the sodium, and then genetic tells us which is the truth. Interestingly, for patients with long QT syndrome type 3, we demonstrated several years ago, when just after the discovery of the involvement of the late sodium current in long QT syndrome type 3 by the group of Mark Keating, we proposed that mexiletine could shorten the QT interval in the LQT3. And in the 22 guidelines, the treatment of LQT3 patients with mexiletine, the physician can choose only mexiletine or mexiletine combined with beta blocker, is something that can actually shorten the QT in the patients. And so it's a treatment that is important. As I have said, the same concept that you need several cells, and as more you move from 1-dimension tissue culture or simulation to 2-dimension and 3-dimension, you need more and more cells. Again, also for the early after depolarizations that are the one present in long QT syndrome that do not develop in the phase 4, but actually develop on the plateau phase, therefore the phase 2 of the action potential. And the concept remains the same, that you need to have multiple cells that oscillates in phase. We have said at the beginning that the typical arrhythmia here is not bidirectional, is torsade de pointe. Torsade de pointe is an arrhythmia that is triggered by early after depolarizations that occur usually in the phase 3. And there are typical initiations profile. So, for example, this short, long, short sequence refers to the coupling of the first beat that is short. Then the next beat is more at a distance. And then there is a final beat that is short again and triggers the arrhythmic episodes. The short couple TDP, the TDP without short couple, the TDP have this typical diamond shape and are called torsade, that in French means twisting. They have, you see, the twisting refers to the fact that here the point of the beat, when I put the arrow, okay, here you see is negative and here is positive. And then after some beats, it goes negative again and positive. So this is the torsion. It means that it changes the polarity of the signal. So it's not like CPVT, that is one-to-one change, is several beats in one morphology and several beats on the other morphology. So another factors that triggers ectopic PVCs, we know is not only in long QT syndrome, is the R on T phenomenon. So a very early coupled PVCs is likely to trigger arrhythmias. And here we can see that one of the mechanisms by which this premature PVC may create an arrhythmia is an arrhythmia that becomes sustained is when a PVC encounter a refractory region with a timing that is critical, and a unidirectional conduction block may occur that may develop in a reentry that stabilizes and can sustain the arrhythmia. And then also, in another version of these premature beats, it may be a PVC that arises from repolarization gradient, because we know that one of the typical characteristics in when the heart of a long QT syndrome patient is mapped is a major dispersion of repolarization, meaning that from one side to the next side of the heart, you may have that the repolarization creates a gradient, so it's not uniform. And this gradient creates the possibility of having other reentrant geometry that maintain the arrhythmia. This is again to show one of these short, long, short, and again the initiation of the arrhythmia, the diamond shape, the inversion of the points. These are positive, these are negatives, and so this is quite typical. And I would like just to mention that these arrhythmias are typical in genetic long QT syndrome, but also the same occurs when patients have the acquired long QT syndrome. That is a mimic of the long QT syndrome type 2, because usually occurs when patients are given medications that block the IKR current. That is the type 2 long QT syndrome genetically. So we also know that bradycardia may be something that promotes the early after depolarization, leading to prolongation of the QT interval during this bradycardia with EAD that becomes quite big. And when they get big, then they become, as we see in these slides, this is an EAD. So this is an action potential. This is the plateau. Here, there is the EAD. The EAD are supposed to originate through a reopening of the calcium channel, so be mediated by the L-type calcium channel. And therefore, this EAD may become big enough to trigger a beat, so becomes like the DAD, the genesis of the first beat that maintains a polymorphic ventricular tachycardia. So we have seen DADs as a triggered activity critical in CPVT, and we see the other type of triggered activity, EADs, critical in long QT syndrome. So these are other examples, of this is a very nice model, long QT syndrome type 2 rabbit. The rabbit tend to have an action potential more similar to humans that, for example, the mice that are not a great model for long QT syndrome because their action potential is very different. They don't have a plateau, for example. And this is just to show, again, that in these instances, the dispersion of repolarization, also in this model, is the factor that creates this substrate where the isochrones get more crowded and a reentry is likely to form and sustain an arrhythmic episode. Very important studies were done already in the 80s, where the presence of this dispersion of refractoriness was confirmed, quantified, and associated with the onset of the arrhythmic events. I try to go faster, otherwise we cannot finish all the things. So one interesting aspect in the field of ablation came from this early pioneering study from the Bordeaux group, where they targeted RVOT and Purkinje ectopies to try to interrupt, and successfully they did it. So these were patients with QTc longer than 460, and so this was at the time the criteria, but were patients that already had documented VT and VF. So in one patient, the PVC originated from the RVOT and was ablated. In two other patients, the polymorphic PVCs originated from the peripheral Purkinje fibers in the LV. And in other patients, the PVC originated for the posterior fascicle. Overall, all these patients were successfully ablated, and the study reported 17 plus minus 17 months of follow-up with no recurrence of VF. So this has started the concept that in these genetic diseases, ablation may be successful, and we know how far this concept has gone. So this is another study, comes from the group of Carlo Pappone, where 11 consecutive patients were also mapped, endo and epicardial. They identify abnormally fragmented, low voltage and prolonged electrocarams, exclusively localized in the right ventricular epicardium. The interesting aspects here is that what the author reports is not only the suppression of the arrhythmia, but also the shortening of the QT interval. At present time, the mechanism for the shortening is not, for the abbreviation of the QT, is not being truly elucidated, but it's definitely an interesting observation, as if that we know already from exilitin that if we shorten the QT, we reduce the arrhythmic episodes. So keep an eye on this, and it may progress with more mechanistic insights. Let's go to therapy. So molecular therapy for long QT syndrome has been developed by the group of Mike Ackerman. And as you remember, when I spoke about the silencing approach that we have used for the ryanodine receptor, we have used RNA approach, so silencing and therefore reducing the amount of mRNA for, in that case, the specific channel. So what they decided to do here has been to silence a long portion of, in this case, the gene that generates long QT syndrome type 1, because they identify a region where several mutations could occur. So this therapy could be used for not just one mutation, one patient, but a cluster of different mutations that are quite frequent in the population of LQT1, treated all at the same time by silencing this long piece of DNA. Of course, if you silence, then you lack a channel, and then you are not doing something good because it's not physiologic. So at the same time, they also placed in their virus the right sequence, so the wild type sequence. So this therapy is called suppression and replacement. So you remove the part, silence, eliminate the part with the mutation, and instead you produce and overexpress, insert the wild type sequence for the gene. So the risk of this therapy is that excessive repression with insufficient replacement or inhomogeneous replacement may create pro-arrhythmic effects. So to make sure that one can get exactly the well balance, that as much as you reduce is that what you replace in wild type, is the key factor in this therapy. But I like to mention this because it can be really a therapy that can work across different mutations. The authors also repeated the same concept in long QT syndrome type 2 and applied for short QT syndrome. So interesting approach that can go across different mechanisms. So in studying arrhythmias and especially developing therapies is very critical to have a right animal model. I was mentioning before that the mouse is not a great model. If we take the action potential, ventricular action potential in humans, and we compare to a mouse, it's very nice that it's easy to make a transgenic mouse with long QT syndrome 1, 2, 3, and all the others. However, we really need to start from an action potential that is similar to the one of humans. So I have said that some authors have used the rabbits with good results. Guinea pig could also be used, but there is no one, as far as I'm aware, that has made a guinea pig genetically modified for the study of inherited arrhythmias. We have recently attempted to make a pig with long QT syndrome type 8. The reason for choosing the pig is that the studies that are going on the use of the heart of the pig as a xenotransplant for cardiac transplantation in humans is born on the basis that the physiology and also the electrical physiology of the pig's heart is one of the most similar to humans. And therefore, a lot of works, especially in the US, are ongoing to create a immunity tolerability heart in a pig, so modify the immunity portion of the heart in pigs, because the pigs of heart seems to be the most suitable for transplanting in men at a time that we have a shortage of hearts in almost all countries in Europe. So we decided to study and investigate a gene therapy for long QT syndrome type A. It's very rare because it's very little. The study that reported the identification of the calcium channel at the abnormal channel in long QT syndrome type 8, the one that I described before, saying that there is a limitation, a dysfunction in the activation of the channel, and therefore the plateau prolongs. Also reported that these children with Timothy syndrome would die as an average of 2.5 years. So it's still a very lethal disease. That very often these children have the defibrillator, but in terms of medications, there are really no medications. There is one feature, is that there are 2 mutations that cause this disease. So in terms of having a strategy, it could be quite promising because we have only to tackle 2 different mutations that are the one that cause this long QT syndrome type 8. So at the molecular level, the mutation is located in a certain region of the heart. But what is important is that at the channel level, we see that the wild type channel opens and then closes. In the same amount of time, a mutant channel open, but really does not close. You see the big difference between the 2. And the consequence of this is that the action potential prolongs and the QT interval also prolongs. Here is our pig with long QT syndrome type 8 in our facility in Madrid. And the objective of the study was at first to characterize the model by using electroanatomical mapping, then extract the heart, measure the electrophysiology in the isolated cardiac cells. So we were lucky, not always a genetic model comes out with a phenotype, but our pigs really had a prolonged QT interval, as you can see here, the mutant versus the wild type pig. And the animal had arrhythmias that, as you see, the diamond of the LQT of the torsade de pointe. We had a 30% mortality in the colony, which was a very good luck as well, because it's a good balance to have pigs who die suddenly, and we could determine that because we implanted loop recorders, but 30%, so it doesn't destroy the colony as if they had 80% mortality. So from our study then, using mapping, we were also able to observe that there were reentrant beats that would initiate the arrhythmias in this model. So we were interested in trying to dissect which was the mechanism that leads to these reentrant arrhythmias. And what we observed is that the action potential was prolonged, that the cells had early after depolarization. But interestingly, we also observed something quite important for thinking about the reentry, because we already have discussed that long QT is associated with dispersion of repolarization. However, this pig having a calcium overload, because there is an excess of calcium ions in the cell that because the channel does not inactivate, this excess of calcium activates CAM kinase, and CAM kinase phosphorylates the sodium channel and in a way that reduces the peak sodium current. So this creates a storm prone substrate, because we have a delay in the propagation, so an activation delay, and then we have a dispersion of the repolarization, and we have the trigger beats originated by early after depolarization. This is the calcium trace, and this is the calcium signal, and we see that there are waves that are the one that generates the arrhythmias. With electroanatomical mapping, we were able to see big differences in the LAT and between the wild type and the mutant. Here we see the homogeneous situation at the epicardium, right ventricular endocardium, left ventricular endocardium, and same for the repolarization. And then we see, of course, in the LQT8, the colors are quite different and represent the dispersion that we have, and the, of course, proarrhythmic substrate and big difference between the mutant and the wild type in both parameters. So, of course, we wanted to develop in this animal model a gene therapy. And so we used the same approach that I had discussed before for the ryanodine receptor, but here in the right setting. Here we have a condition in which we have only two mutations. So with two silencing molecules, we could really tackle the two types of long QT syndrome type 8. What you are seeing here are cells isolated from a heart that has been infected with the gene therapy made of a virus, an adeno-associated virus, that instead of being able to replicate himself, had his DNA removed. We placed inside the silencing molecule that would reduce the number of the calcium channels that are mutant. We also would put in this virus a green fluorescent protein. So here you see all the cells after isolation, and here you see the cells when we are creating in the microscope conditions for showing the cells that are green. Then this kind of experiment is very useful because you can do patch clamp in the gray cells that are the one that should be sick, and the green one that should be the one that have been restored and cured. So here we see the calcium current. So in the non-infected cells, these cells, you see that the current opens and it does not inactivate. But in the green cells, after they've been treated and where we have reduced the number of sick channels that generates this non-inactivating current, we see that the cells have a normal behavior. And this opens to the possibility that then also the abnormalities that we see with mapping would be recovered. Good signal that the QT duration was shortened because, of course, this persisting current is the reason by which the plateau prolongs. And here in the cells that inactivates, this actually shortens the action potential and therefore tend to normalize, as we see in this data as compared to before the treatment or the non-treated. But most exciting was to see that when we repeated the mapping, wild-type pig, Timothy syndrome pig before therapy, treated Timothy syndrome pig. And we see that all this dispersion of the repolarization is modified, dramatically reduced, strongly reduced in the treated pigs. And the same, the LAT, here we see the different scenario in epicardium and in the right and left ventricle. And here we see again the normalization, I would say, also of the LAT in the treated pigs. So this is quite an exciting scenario for the future, how the gene therapy can actually be informative, and especially large mammal models can be the future for going so much in the detail of seeing how much the gene therapy can be effective and follow the animals, because of course these animals live much more than the mice that have a much shorter lifespan. And now we conclude with Brugada syndrome. Here are the typical electrocardiogram. I think that in Brugada syndrome, we have not made yet all the advancement that we have made in the understanding and in the versatility of the potential treating approaches that we can design. So, as we know, Brugada syndrome is another of the arrhythmogenic channelopathy diagnosed by this ST segment elevation that is called the type 1. This is usually observed between 1 and V1, V2, and V3, but with different morphology. Not always all the three leads, V1, V2, and V3, are elevated. And the elevation is considered diagnostic when it is more than 2 millimeters, more or equal than 2 millimeters. So it has been also demonstrated that the anatomy can modify the spaces, the intercostal space where you best can see the ST segment elevation. Therefore, the guideline now recommend that the recording in different intercostal space should be positioned to account for the conformation of the thorax of the patients that can be short and large or can be narrow and longer, and therefore to try not to miss something related to the anatomy and not related to the fact that the patient is negative to the ST segment elevation. So the guidelines really recommend the adoption of this more inclusive and more positive, probably, kind of approach. Then there is also the concept that remains quite debated of the use of the Ashmelin test to induce a type 1 pattern. The concept is that in patients that have a pattern type 2 or type 3, so not really the coved pattern, the Ashmelin can unmask or induce the type 1 pattern. And therefore, the concept becomes that the number of individuals among family members that one can identify responsive to Ashmelin and having therefore an induced pattern, not a spontaneous pattern, may remain healthy for their entire lifespan. Therefore, there is an unsolved debate on the use and the importance or non-importance of doing this Ashmelin test. This matching, these difficulties matches also of a very meager contribution of genetic testing in diagnosis of Brugada syndrome, where of many channels that were initially associated with this as being the substrate of Brugada syndrome, only the sodium current is currently considered the only gene demonstrated as causative of the Brugada syndrome. It is also known that if the patient has a truncation in the sodium channel, the abnormality and the phenotype of the patients can be more severe. But we really still, as compared to how much I have talked about the re-stratification, the treatment, the gene therapies in the other two diseases, we are very distant to get this richness of understanding of the substrate and therefore to design management for these individuals. Interestingly, a polygenic risk score has also been proposed. What is a polygenic risk score? This is just to show you an onset of arrhythmias. As I have said before, mentioned before, these patients go very rapidly into VF, do not have torsade, do not have bidirectional or very long stretches of polymorphic DT, some other example. So this is just to show that of all these different genes, only this one survived, and only this one should be screened and should be considered causative if a mutation, pathogenic or likely pathogenic, is identified by your genetic laboratory. So this concept is quite fascinating, and it says that there are variants that are not variants that modify the sequence. They may be completely silenced. They may not change the amino acid, but yet they may be associated with some tendency to induce the ST segment pattern elevation. And therefore, the more of these variants you have, the higher is the probability that the patients will develop the phenotype. So this has raised another concept that at present time doesn't really have a practical approach. So it is not done in the clinic, the assessment of whether your patient has these common variants, has 1, 2, or 3. And therefore, we are waiting to anticipate whether in some forms we could add this concept that variants that are not deleterious but still are different than what the majority of us has can be another component useful for risk stratification. So keep in mind that this means that now why it is established long QT syndrome is a genetic disease, mainly autosomal dominant. CPVT is a genetic disease, autosomal dominant for the RYR2, recessive for the calsequestrin. In Brugada syndrome, we have another concept. There is one gene that identifies patients as autosomal dominant disease Brugada, affected by autosomal dominant Brugada, but there is another component that may, at some time, change the scenario and introduce that maybe we should take a look also at this single nucleotide polymorphism. So this means that while other conditions are mainly monogenic, that have either all one gene or one mechanism, here, at least partially, a component of variants that are not pathogenic but are modulator of the pathogenic substrate may become important for Brugada syndrome re-stratification. And we wait and cannot really make many comments so far. This polygenic risk score has been extended with the addition of other polymorphism, but two studies published so far have not associated with the risk of events. So they seem to confirm and increase the possibility that the patient shows the Brugada pattern, but nothing yet about the risk. So on the mechanism, there is this debate between depolarization theory, repolarization theory, and of course, a theory in the middle that could be maybe both can have a role, or maybe each patient may have more depolarization-induced arrhythmias or repolarization abnormalities-induced arrhythmias. So basically, patients affected and genetically characterized are quite few. It is estimated that only 50% of the patients carry an SCN5A loss of function mutation, so the only gene that we have is quite rare in the population. So we don't really have a lot from genetic to understand. However, these loss of function mutations reduce the sodium current, and these can prolong the activation and the duration of the activation in sinus rhythm. There are also increased electrogram fractionation in these patients. And as we know, this is then the reason and the rationale for the ablation that is now the only therapy that has emerged for these patients: activation delays on premature stimulation and abnormal conduction velocity and its restitution. So good reason for thinking that is the activation components that contributes. But there are also reasons and factors for a repolarization. And if we think what we have said about the other diseases, it is often common that there is an abnormality, generally a slowing of the activation and a dispersion of the repolarization. In this case, we also have, the evidence of structural alteration. As we remember, Brugada syndrome at the beginning was strongly debated as not being an identity, a different disease, but being part of arrhythmogenic right ventricular cardiomyopathies. And in Italy, especially, the Padua group has brought different evidence in support of this hypothesis. And as a matter of fact, studies have identified that there might be desmosomal abnormalities also in some patients with Brugada syndrome, even if desmosomal genes and mutation in desmosomal genes have not been reported as causative of the typical electrocardiographic feature of the Brugada patients. So the heart, for many years, it was called a normal heart. But then at the beginning were endocardial biopsy performed by Frustacci in Rome that demonstrated structural alteration in patients with Brugada syndrome. So the concept that was hypothesized was the presence of a myocarditis that may predispose then to alter the substrate. But if this has not been confirmed, yet this concept really went in the direction of thinking that there was more in the substrate, the anatomical substrate of the Brugada, worth investigation. And here is what I have said before, the interplay between the connexome, that are all these desmosomal protein, and the connexin 43, and the conduction abnormalities that bring support to the concept that the disease may have a component of its arrhythmogenicity that is related to alteration in the conduction and in the propagation and in the genesis of the action potential. There is also a repolarization theory, of course, that is mainly focused on the fact that in Brugada syndrome we may have this morphology at the level of the epicardium and a normal, or like the normal, morphology in the action potential in the endocardium. And if there is this difference may create a gradient where current is flowing from one region to the other. And by doing that, by creating this heterogeneity, it may create what is called a phase 2 reentry that may generate premature beats. And these premature beats may create arrhythmias that then becomes a sustained arrhythmia. So there are actually reasons for thinking that there is an activation component and a repolarization component as well. And the debate has not been sorted, but still both things may occur. Whether they have to occur at the same time for having the arrhythmias is probably not demonstrated at this moment, but that there are multiple abnormalities that may contribute to creating this arrhythmogenic substrate seems to be quite supported by the different data shown for the evidence of one or the other. So for a long time, the programmed electrical stimulation and the implant of the ICD has been almost the only approach for the patients with Brugada syndrome. It is known that at variance with the other diseases we have discussed this morning, here it seems to be not the adrenergic nervous system, but rather the parasympathetic activation, as the patients have more episodes of ventricular fibrillation during the night hour. And in fact, in the clinic, we realized that patients quite frequently have their events during sleep. That, of course, increase the mortality as they may go unnoticed. They may be in their house alone. And therefore, this night mortality is something that has been really confirmed in many different studies. Interestingly, also, it has been demonstrated that arrhythmic storms and repetitive arrhythmias can be suppressed by isoproterenol. And this also is at variance with the conditions that we have discussed before. And that ST segment elevation decreases during isoproterenol administration. It also decreases during exercise stress test, and it comes back during the resting phase when the vagal activation may become the predominant one. So there have been observations that have also supported this concept that isoproterenol might be protective, while acetylcholine may exacerbate the transmural gradient and may act and do this by inhibition of the calcium current in the epicardium, as these data have suggested. Still, beside the fact that the storms are treated with isoproterenol, the adrenergic modulation in one sense or the other, so increasing the adrenergic activation or decreasing the parasympathetic, has not made a step to being a therapeutic modality in the prevention phase of the patient. So then, again, pioneering insights from Bordeaux in ablating the RVOT in Brugada syndrome. Interestingly, the concept that is the right ventricular outflow tract goes back to the ideas that there is some interrelationship or similarity between arrhythmogenic right ventricular cardiomyopathy and Brugada syndrome, but I still repeat that arrhythmia generated by mutations in desmosomal genes in Brugada syndrome have not been described, or definitely do not seem to be in the majority of the patients. So the genetics still remain confined to the sodium channel. So in this early study, arrhythmias substrate was identified in patients with Brugada syndrome, and the triggers in the right ventricular outflow tract were ablated. Ablation prevented ventricular fibrillation inducibility induced by programmed electrical stimulation. As you know, programmed electrical stimulation has been largely debated, reproducible, not reproducible, truly a tool for restratification or not a tool for restratification. So a lot of debate has been going on for many years, and still today there are contradictory positions in this. Anyhow, one study has demonstrated that not for ablation probably, but in the setting of restratification, it is better to do programmed electrical stimulation with 2 extra stimuli rather than 3, because with 3, the predictive value decreases as more false positive substrate gets identified. It's only one study, but was a multi-center study with patients from different countries. So probably some meaning in this conservative approach in programmed electrical stimulation for restratification may have some rationale. So this started the moment of thinking that ablation could be a therapy for the Brugada patients. And this, as you know, has been developing and evolving, and has gone on with the studies on the Nandamani that has made a major contribution in this field by studying different populations in Thailand and in the United States. And I think that overall, from the initial study, Nandamani and collaborators have progressed to this Bravo trial that is now solid evidence from a relatively large number of patients with Brugada syndrome and occurrence of spontaneous ventricular fibrillation that after a single ablation remained free of recurrency or life-threatening arrhythmias, reduction of the VF burden, reduction of frequency of shocks, of course, with the reduction modification of the substrate, And Kaplan-Meier, we have free survival beyond 5 years in 95% of the patients. So quite successful approach and confirmation that this could be a good approach. I have only one slide for a gene therapy proposal. I want to mention, because this is a little bit different, so it's not modulating the substrate, but starting from the evidence that the peak sodium current is reduced in the Brugada syndrome patients, as we know. The possibility of giving with gene therapy a factor that improves the trafficking of the channel, as called MOG1. It was considered at the beginning as a gene causative of Brugada, but now is known that it's not a causative gene, but rather is a protein that may increase the trafficking of the sodium channel. So as a rationale for the molecular treatment of Brugada syndrome. I have one concern on this, because if you have a truncating mutation, probably MOG1 is okay. But if you have a mutation that reduces the function of the sodium channel, you may still increase the trafficking also of the mutation, and therefore this may limit the effect of this therapy. And with this slide, I want to conclude and say that fundamental science is really relevant and has highlighted many features over the years and the work of many laboratories. The genetic defect is an important factor that may be diagnostic, but may also be an indicator of which therapy should be used in the patients. The dissection of transcriptional changes, modification of protein expression, really points to gene therapies as a possibility of getting close to the cure of this condition. And of course, for the time being, at least in Brugada syndrome, the ablation approach seems to become the best approach, still not approved for all the patients, but according to the guidelines, definitely an indication for patients who have had multiple cardiac arrest. Thank you very much for your attention.
Hi, you hear me, right?
Yes, I hear you.
Okay, great. So thanks for the talk. I have a question. Okay, you said that Agmalin test can be positive on healthy patients. So just imagine you have a patient that has tested positive on Agmalin, but it has no sudden cardiac death events in all their lifetime, and neither familiary familiary like events neither, and it hasn't neither like positive genetics. Will you still consider this patient like a Brugada patient?
Yeah, I think that we are missing a study that strongly demonstrates the difference in prognostic outcome. There are some reports that the induced ST segment elevation is not as severe. So there are data showing that, for example, the occurrence of arrhythmic events over long follow-up are around 3-4%, so very low. Yet there are some patients that get unmasked by the Ashmalin test and maybe 10 years later develop an event. And so this sort of confuses and dilutes. I am personally awaiting that the field evolve into the demonstration that we should not perform all these Ashmalin tests that now are indicated in some center for all the family members of a case of Brugada needs to do Ashmalin test. This brings really what you are referring to, what looks very much like an overdiagnosis. However, there is some sense of some responsibility, no? Until there is not a position from guidelines or consensus documents that we should stop trying to identify the family members, especially since in Brugada syndrome, we don't have the backup support that someone really is induced and has a mutations that is a pathogenic mutation, and therefore at least two things concur to the evidence of maybe an incompletely penetrant disease, but still a disease present. I'm afraid that we are all going in the direction of overdiagnose that psychologically impact the patients and leave us with little possibility of doing something good, because definitely we are not sending these patients for ablation. It's not indicated in the guidelines and not in the common sense as well. We don't have medications. Maybe quinidine can be given, but it's not an easy treatment for a person like the one you report with no history whatsoever. So we really need, I think at this point, not something that tell us what to do, but maybe for once guidelines should gather sufficient evidence to say we should not do all these Ashmolean tests. But until that comes from an official document, it's difficult to do. And I share with you the concern and the disappointment for that.
Okay, thank you so much.
Hi, thanks for your great talk. I have just a question. I would like to come back on your gene therapy on the CPVT. So you suggest to use myRNA with either against the mutant or to propose to increase calsequestrin. But I have just a question about your cDNA coding the MIR. Is stay in episomal form or is it include in the DNA?
Sorry, I've not understood this last part. Can you repeat it?
My question is just the inhibitory RNA that you use in your gene therapy stay in episomal form in the nucleus, but not include in the DNA, or is include in the DNA?
The episomal structures is in the cytoplasm. It's located in the cytoplasm and at the beginning, and then it travels to the nucleus and stays there. So actually the concept that this the AV associated viruses are used is really because the gene therapy seems to last 6-7 years after a single injection, exactly because it resides in a protected area, both for the DNA therapy and the RNA therapy. Is that the question that you had?
Yeah, it's just for the clinical parts. What is the best to include or not the cDNA to in order to have persistent expression of the gene therapy? It's the best you answer.
So the cDNA, we use the cDNA when we have to replace a protein, but in the case of the silencing, we need to do it with RNA because the mechanism RNA interference is done with an RNA molecule. So we have no cDNA in that.
Okay, so you have to inject several times your treatments for animals or patients.
So this comment leads to how long the RNA therapy will last. So far we have seen in our mice 1 year, but the limitation is not the 1 year, meaning that after 6 months it would be gone, but that is difficult to keep in the cage the mice for more than 1 year because they age at that point, they become fat and so on. So we have been able to test up to 1 year. Now that we have this swine model where we are also using the RNA interference, we are planning to do 5 animals that we want to keep long term and give an answer to this question that is very important because there are really no data on the duration of the RNA therapy.
Okay, thanks a lot.
Sure.
Thank you for a very nice oversight. Do you think there's still a role in CPVT for cardiac sympathetic denervation?
Oh, yeah, I think that in CPVT, we need to play by ears, know all the tools and the approaches that we have, and use them depending on the patient's preference, our risk stratification model, the previous history of the patients. I think that in the guidelines 2022, in CPVT, the ranking of what to do in a patient who has failed on medical therapy, so patients who received a non-selective beta blocker, failed, addition of flecainide failed, what to do next, they place as an option of the physician either to go with the defibrillator or to go with the denervation. Of course, the ICD has limitations that we know and have been discussed over the years as limitation of the defibrillator, like the inappropriate shocks. Now there is the sub-Q, so maybe the issues about the leads have been reduced. And then, we have the problems of the denervation that not all the centers may have access to someone expert in doing denervation. So the guidelines has kept this approach of saying after the failure of the drug therapy, either or. And so I think that each physician is free to decide what to do or to do what he or she has access to. So there is not really a ranking, but definitely not to say or imply that denervation is not effective.
Okay, thank you.
Sure.
Hi, yeah, I also have a question. Thank you for your talk. You said, or you mentioned that also a defibrillator could be the strategy, but isn't it leading to more release of what causes it actually, of the hormones, the catecholamine, adrenaline, and so on?
Well, we have 70 patients with CPVT implanted with a defibrillator, and in none of them we have observed a storm, because what you are describing, of catecholamine shocks, pain, and adrenaline release and recurrence, and therefore a storm, is what happens. I think that a lot has to do with programming of the defibrillator, that you need to give sufficient time for the shock to occur and not have a very premature shock, very early on shock. At least we think that this is why we have had no storms in our patients in which we have implanted the defibrillator. My concern for the denervation is that with the denervation, you never really know how much of the sympathetic below the stellates has been removed. And so if it's really complete or is not complete. Even the inspection of the samples removed after the denervation is not very easy, the pathologist says, to really know how many ganglia have been removed. And so that would be sufficiently effective. We have patients that have been denervated and failed on the denervation. And so patients, 2 or 3 patients we have like that over the years have required then to go on the defibrillator because they still had recurrences. It's interesting, but with no answer, but I wonder whether after maybe 7, 8 years, there is some form of reinnervation in the heart of the patients, or is that is something we cannot count on? Just a question that would be very interesting to know and to clarify.
Okay, thank you.
I have a question about the programmation of the defibrillator in the patient with catecholaminergic VT. Is there any specificity in programmation? For example, in the Bugrass syndrome, we don't need a TV zone, and we can go directly to the VF treatment. So what do you think about that?
Yeah, I totally agree with you. An important consideration of the defibrillator is not to turn on the ATP, because actually, in the CPVT, the fast pacing triggers delayed after depolarization. So it's really important that it's not turned on. We have seen several patients coming to us with a defibrillator shock, and then the problem was that there was ATP on. So I fully agree with you on that.
Yeah, thank you. Do we have any other questions? Okay, so thank you very much, Dr. Priori from Italia. Thank you.
Thank you very much.